Welcome to Lesson 2 of your antepartum unit. In this lesson, we will cover the concepts associated with pre-existing conditions that result in high-risk pregnancy. The objectives of this unit will include distinguish the types of diabetes mellitus in pregnancy with the corresponding risk factors in pregnancy, associate the insulin requirements during each stage of pregnancy, postpartum period, and with lactation, recognize maternal and fetal risks or complications associated with diabetes in pregnancy, develop a plan of care for the pregnant woman with pregestational or gestational diabetes, identify the risk factors associated with the management of the patient with hyperthyroidism, hypothyroidism, cardiovascular disorders, respiratory disorders, anemia, neurologic disorders, and autoimmune disorders. Discuss the care of pregnant women who use, abuse, or are dependent on alcohol, illicit, or prescription drugs. For most, pregnancy is a normal, happy occurrence, but for some women, pregnancy presents a significant risk to both mother and fetus based on pre-existing conditions. This lesson focuses on the pre-existing conditions that increase risk for both mother and baby. Pre-existing conditions include metabolic disorders, which include diabetes mellitus and thyroid disorders, cardiovascular disorders, respiratory, gastrointestinal, integumentary, and central nervous system disorders, autoimmune disorders, and substance abuse. First, we will discuss diabetes. The perinatal mortality rate for the pregnant woman who has diabetes is about the same as it is for the non-diabetic mother, with one caveat: the diabetes must be well controlled. If the diabetes is not well controlled, the risk increases. Therefore, the goal of managing the care of the pregnant woman who happens to have diabetes is to assist the mother in maintaining strict glucose control. Diabetes is a metabolic disorder in which hyperglycemia is the result of a defect in insulin secretion, insulin action, or both. In the normal person, insulin, which is produced by the pancreas, regulates glucose by assisting glucose to enter the adipose and muscle cells where it is used to produce energy. Insulin is the key for glucose to get into the cell. Without insulin, glucose, no matter how hard it tries, can't get into the cell. Diabetes is currently classified into 4 groups: type 1 diabetes, type 2 diabetes, and other specific types. These are pregestational diabetes. And then there's gestational diabetes. White's classification of diabetes in pregnancies is based on the age at which diabetes was diagnosed and is used to assess both maternal and fetal risk. Women who are Class A through Class C generally have positive outcomes. Women in Classes D through T usually have poor pregnancy outcomes. During pregnancy, there are complex alterations in maternal glucose metabolism, even in a normal pregnancy. These adjustments in glucose metabolism allow for adequate nutrition for both the mother and the baby. The fetus receives glucose from the mother as glucose is transported across the placenta. However, insulin does not cross the placenta. Around the 10th week gestation, the fetus secretes their own insulin. When maternal glucose levels rise, fetal glucose levels rise, resulting in an increase in insulin secreted by the fetus. During the first trimester, the pregnant woman's metabolic status is affected by the increase in estrogen and progesterone. Because of the hormonal influence, the beta cells in the pancreas are stimulated to increase insulin production. This leads to an increased peripheral use of glucose and decreased blood glucose, which in turn reduces fasting glucose levels by 10%. At the same time, an increase in tissue glycogen stores and a decrease in hepatic glucose production occurs, which decreases fasting glucose levels even more. As a result of these changes, a nurse would expect insulin needs of the insulin-dependent diabetic mother to decrease. During the second and third trimesters, a diabetogenic effect occurs. The hormonal changes during these trimesters result in a decreased glucose tolerance, increased insulin resistance, a decrease in hepatic glycogen stores, and increased hepatic production of glucose. Insulin needs gradually increase from 18 to 24 weeks to approximately 34 weeks. The insulin-dependent pregnant woman might find that her insulin requirements double or quadruple during this time. In clinical experiences, we once cared for a diabetic mother whose insulin requirements were so high that we double and triple checked the doctor's order. Quite surprising and a little scary. During the postpartum period, in fact, immediately after the expulsion of the placenta, the levels of circulating placental hormones drop. The mother returns to pre-pregnancy insulin sensitivity levels. If the mother is breastfeeding, insulin levels may remain lower than pre-pregnancy requirements. Producing breast milk requires energy, which uses up glucose. This slide shows a graph of insulin needs based on gestation, and you can see through the first few weeks the level remains a little bit higher than normal, and then right before week 13 the level drops significantly and remains low until about 20 weeks, and it starts rising until you see at 36 weeks where the insulin needs peak. Of all the pregnancies complicated by diabetes, only 10% are the result of pregestational diabetes. Almost all women with pregestational diabetes are insulin dependent during pregnancy. Since the normal hormonal changes in pregnancies affect glycemic control, insulin needs in early pregnancy are lower. Insulin needs can be further decreased by nausea, vomiting, and cravings, which are typical in early pregnancy. It is important to monitor the diabetic mother early in pregnancy for hypoglycemia, as insulin dose may need to be decreased. For the diabetic woman who is considering getting pregnant, it is very important that she receive preconception counseling. In this preconception counseling, the optimum time for pregnancy can be discussed. Also discussed is the importance of establishing glycemic control prior to becoming pregnant. The woman partner needs to be involved in preconception counseling. There are risks to both mother and baby. Maternal risks include poor glycemic control, which can lead to miscarriage and macrosomia, preeclampsia, preterm birth, cesarean birth, increased maternal mortality, hypertensive disorders, hydramnios, infections, ketoacidosis, hypoglycemia. The fetal and neonatal risks of diabetes include stillbirth. 2 to 5% of all fetal deaths occur in women whose pregnancies are complicated by pregestational diabetes. Congenital malformations, which accounts for 30 to 40% of perinatal loss in pregnancies complicated by diabetes. Birth defects caused by hyperglycemia during the first trimester of pregnancy when organs and organ systems are forming. And macrosomia, which can lead to birth injuries such as brachial plexus palsy, facial nerve injury, humerus or clavicle fracture, and cephalohematoma. Antepartum care of the diabetic mother includes a complete evaluation of health status. During a thorough interview and physical examination, the nurse should assess for the effects and complications of diabetes. Routine lab tests should be performed with a 24-hour urine collection to assess baseline renal function, urinalysis, and urine culture to assess for UTI, and a glycosylated hemoglobin to A1C to assess long-term glucose control. The pregnant patient with pregestational diabetes need to be monitored more frequently. During the first and second trimesters of pregnancy, prenatal visits will be scheduled every 1 to 2 weeks. In the last trimester, she may be seen as frequently as 2 times each week. During the antepartum period, it is very important to maintain strict control of glucose levels. For this reason, the woman must have a consistent daily schedule. She should wear a medical alert bracelet and carry appropriate supplies to cope with diabetic emergencies such as insulin, syringes, and sources of fast sugar. Diet must be managed based on glucose levels, blood and not urine. Calorie consumption should be controlled. For the non-obese woman, 30 to 35 kilocalories per kilogram per day. The obese woman should have 25 kilocalories per kilogram per day. If the physician prescribes it, the woman should perform aerobic exercise with resistance training for 30 minutes a day most days of the week. Blood glucose should be monitored before and after exercise. Insulin needs are increased during the first trimester from weeks 3 through 7, followed by a decrease between weeks 7 and 15. During the second and third trimesters, with the advent of insulin resistance, the dose must be increased significantly. The woman with type 2 diabetes, previously treated with oral medications, will need to learn to administer insulin. Common insulin preparations are noted in your book. Acceptable fasting glucose levels are generally between 65 and 95 milligrams per deciliter, and 1 hour post-meal levels should be less than 130 to 104 milligrams per deciliter. The woman should be taught to report episodes of hypoglycemia with a blood sugar less than 60 and hyperglycemia and blood sugar levels greater than 100. Fetal surveillance must also occur. A baseline ultrasound will be done to assess accurate gestational age and due date. Follow-up ultrasounds are recommended every 4 to 6 weeks to monitor fetal growth, estimate fetal weight, and detect hydramnios, macrosomia, and congenital anomalies. Because of the increased risk of neural tube defects, a maternal alpha-fetal protein is performed between 15 and 20 weeks gestation. A fetal echocardiogram may also be performed between 20 and 22 weeks gestation to assess for cardiac anomalies. In the third trimester, the NST is preferred method to evaluate fetal well-being. This usually begins at 32 weeks. During the intrapartum period, when the mother is in the labor and delivery unit, it is very important to provide appropriate intrapartum care. A part of this intrapartum care is to monitor the patient closely to prevent complications of dehydration, hypoglycemia, and hyperglycemia. If glucose levels fall below 70, the IV fluids will be changed to 5% dextrose. Regular insulin may be infused via piggyback. Blood glucose is checked every hour to maintain the level at 140 milligrams per deciliter or less. The patient may require a cesarean birth. In the postpartum period, due to the absence of the placental hormones, insulin requirements decrease substantially. They may require only 1/3 to 1/2 of their last pregnancy insulin doses on their first partum day. Breastfeeding should be encouraged. Infants of mothers with type 2 diabetes have a 70% likelihood of developing diabetes later in life. Breastfeeding seems to have an anti-diabetogenic effect. Insulin needs are decreased in the diabetic mother who breastfeeds due to the fact that glucose is used as energy in milk production. Contraception counseling should also be considered before the patient is discharged. Next, we're going to discuss gestational diabetes. Gestational diabetes complicates 3 to 9% of all pregnancies. It is more likely to occur in Hispanic, African American, Native American, and Asian women than in Caucasian women. Classic risk factors for development of gestational diabetes include a family history of diabetes and previous pregnancies that resulted in an unexplained stillbirth or birth of a malformed or macrosomic fetus. Other risk factors include obesity, hypertension, glycosuria, and maternal age greater than 25 years. There is no increased risk of birth defects in the infant of a gestational diabetic mother, with the exception of the mother who was obese prior to becoming pregnant. In this case, an increased risk of neural tube defects has been found. Screening for gestational diabetes. The most used method for screening for gestational diabetes is a two-step process. In step 1, the mother drinks a solution with a 50-gram glucose load and has a plasma glucose level drawn 1 hour later. A glucose value of 130 to 140 milligrams per deciliter is considered a positive screen. If the screen is positive, the second step is initiated, in which a 2 to 3 hour 100-gram oral glucose tolerance test is performed. The oral glucose tolerance test involves having the mother fast the night before the test. following an unrestricted diet for 3 days prior to the test, and have no caffeine as it increases glucose levels. For the mother who smokes, she should not smoke for 12 hours prior to the test. First, a fasting blood glucose level is drawn. Next, a 100-gram glucose load is given orally to the mother. Then blood glucose levels are drawn at 1, 2, and 3 hours later. If 2 or more of the values are met or exceeded, gestational diabetes is diagnosed. As you can see on this slide, it shows you the decision tree you'll make based on the results of the 1-hour test. And if 2 or more of the values of the 1 hour or the 2 hour or the 3 hour are met, fasting at 95, 1 hour at 180, 2 hour at 155, and 3 hour at 140, gestational diabetes is diagnosed. So the diagnostic indicator is a positive screen followed by a positive glucose tolerance test. The antepartum care of the gestational diabetic is centered on maintaining a euglycemic state. Therefore, the goal is strict blood glucose control. Normal fasting blood glucose levels are the same in gestational diabetes as they are in pregestational diabetes at 65 to 95 milligrams per deciliter, and 1 hour post-meal blood glucose levels should be at 130 to 140 milligrams per deciliter. Dietary modification includes the same calorie recommendations as in pregestational diabetes. Exercise recommendations are the same as in pregestational diabetes. However, evidence has shown no improvement in pregnancy outcomes in the gestational diabetic who performs cardiovascular exercise. If the woman is obese, evidence has shown a decrease in need for insulin with exercise. Blood glucose monitoring is individualized but generally done upon rising, after breakfast, lunch, and dinner, and at bedtime. Not all women who are diagnosed with gestational diabetes need to have insulin. About 25% are able to maintain the euglycemic state through complying with diet measures. Insulin is prescribed when fasting glucose levels are greater than 95 milligrams per deciliter or 2-hour post-meal glucose levels are greater than 120 milligrams per deciliter. While insulin is the preferred method of maintaining blood sugar levels in the gestational diabetic as it does not cross the placenta, oral hypoglycemic medications can be used. Glyburide is the most frequently prescribed oral hypoglycemic as only minimal amounts crosses the placenta. Studies have shown that there is no increase in macrosomia in infants of mothers who take glyburide. However, an increased incidence of neonates who require phototherapy or have birth injury are noted. Metformin may also be used. While metformin does cross the placenta, no teratogenic effects have been noted. In the mother who has her gestational diabetes well controlled, no increase in fetal surveillance is warranted. However, if there are other complications or those who require insulin, twice-weekly NSDs should begin at 32 weeks. During labor, blood glucose levels need to be monitored to maintain levels at 80 to 120 milligrams per deciliter. Maintaining this blood sugar level decreases the incidence of neonatal hypoglycemia. Most women return to normal glucose levels after childbirth. However, the recurrence risk for gestational diabetes in the next pregnancy is 35 to 75%. There are other metabolic disorders of pregnancy. Hyperthyroidism in pregnancy is rare. The signs and symptoms of hyperthyroidism are similar to those of pregnancy. In order to differentiate the symptoms of hyperthyroidism, the nurse should look for weight loss, goiter, and a pulse rate greater than 100. Untreated hyperthyroidism in pregnancy can lead to increased risk for miscarriage, preterm birth, giving birth to stillborn infants or infants with goiter, hyperthyroidism, or hypothyroidism. Hyperthyroidism in pregnancy is treated with propyl thyrouracil or PTU or methimazole, MM. The dose of PTU is 100 to 150 milligrams 3 times a day. Women who breastfeed and continue to take the medication after birth are advised that the medication does not seem to adversely affect the neonate's thyroid function. Hypothyroidism occurs in 2 to 3 out of 1,000 pregnancies. It is associated with increased risk of miscarriage. If left untreated, there is an increased risk of miscarriage, preeclampsia, gestational hypertension, placental abruption, preterm birth, and stillbirth. Medications are given. Levothyroxine or Synthroid is beginning at 0.1 to 0.15 milligrams per day, adjusting by 24 to 50 micrograms every 4 to 6 weeks as necessary based on TSH level. Maternal phenylketonuria, a cause of cognitive impairment, is an inborn error of metabolism caused by an autosomal recessive trait that creates deficiency in the enzyme phenylalanine hydrolase. My Diet Pepsi states in bold, phenylketonuria contains phenylalanine. PKU affects 1 of every 10,000 to 15,000 Caucasian newborns. PKU is treated by strict dietary modification. Women with PKU should be advised against breastfeeding due to the high concentration of phenylalanine in breast milk. Now let's discuss the cardiovascular disorders that affect pregnancy. Normally, the maternal cardiovascular system goes through major changes as a result of pregnancy. There is an increase in intravascular volume. All you have to do is check out the veins of a pregnant woman and you can see this. The pregnant woman also has a decreased systemic vascular resistance, changes in cardiac output during labor and birth, and intravascular volume changes immediately after birth. We'll also discuss the cardiovascular disease classification system. The Class 1, Class 2, Class 3, and Class 4 determined at 3 months and again at 7 or 8 months of gestation as progression may occur. We'll discuss the antepartum assessment of the cardiovascular patient and the plan of care and implementation. The normal heart has no problem compensating for pregnancy. The diseased heart is another story. There is an increase in the number of pregnant women with cardiovascular disorders who are becoming pregnant. A part of that reason is that due to advancement in the treatment of congenital heart defects, infants born with these defects are now living till childbearing age. This is a New York Heart Association classification system of classes cardiovascular disease. They use this classification system in pregnancy. With Class 1, there's no limitation on physical activity and there's no overt symptoms. With Class 2, there's a slight limitation on physical activities. And comfortable at rest but ordinary physical activity can cause symptoms of heart failure. With Class 3, there's a marked limitation in physical activities. The patient is comfortable at rest but less than ordinary activity causes symptoms of heart failure. With Class 4, they have the inability to carry out any activity without symptoms. And with this patient, you have the presence of symptoms even at rest. Now let's discuss the specific defects. With an atrial septal defect, the woman may not even be aware she has one until she does get pregnant. Some women with ASD may develop CHF symptoms or arrhythmias in pregnancy. Ventricular septal defect is usually diagnosed and corrected early in life. Women who have a small, uncomplicated VSD usually have no problems. There is a higher risk of heart failure and pulmonary hypertension in women with a large VSD. Surgery should be done in the woman with coarctation of the aorta prior to pregnancy. However, with non-complicated coarctation, pregnancy is usually fairly safe. The complications that can occur include hypertension, congestive heart failure, CVA, aortic dissection, and rupture of associated aneurysms. Tetralogy of Fallot is the most common cyanotic heart disease in pregnancy. Surgery is highly recommended prior to pregnancy due to the decrease in blood flow through the pulmonary circulation, which can lead to hypoxemia, syncope, or death. The most dangerous time for these women is in the third trimester when venous return is reduced by the gravid uterus and early postpartum, and when there is peripheral venous pooling immediately after birth. Mitral valve prolapse is a common benign condition. Pregnancy generally does not cause a problem unless endocarditis occurs. Prophylactic antibiotics are given. Mitral stenosis is most often caused by rheumatic heart disease. Maternal mortality is related to the functional capacity, with most deaths occurring in Class 3 or Class 4. Prophylactic antibiotics are given. In addition, diuretics, usually furosemide, are given to prevent pulmonary edema, and beta blockers or calcium channel blockers may be given to prevent tachycardia. Care is managed through reduction of activity, restricting sodium, increasing bed rest, and medication. Pain must be controlled during labor, with epidural pain management preferred. Avoid the lithotomy position in labor and birth. Vacuum and/or forceps birth is recommended to decrease the cardiac workload. Aggressive diuresis is recommended after birth because fluid shifts place the patient at risk for pulmonary edema. In the woman with Class 3 or 4 disease, surgery is recommended during pregnancy if symptoms cannot be controlled. Aortic stenosis is rarely seen as it normally develops after the childbearing years. However, if it occurs, treatment is similar to the treatment of mitral valve stenosis. There are other cardiac conditions that occur less frequently with specific management for each. These can be found in your book. The antepartum focus of care of the woman with a cardiac disorder is on minimizing the stress on the heart. Anything that significantly increases cardiac workload is avoided. Measures that can be taken to decrease workload include treatment of emotional stress, hypertension, anemia, hyperthyroidism, or obesity. Nutrition counseling may be used. Stool softeners and cardiac meds may also be administered. In the intrapartum period, routine assessments are done with the addition of ABGs and possible hemodynamic monitoring. Again, nursing care is focused on promoting cardiac function. Maintain a calm atmosphere. Elevate the patient's head and shoulders and place in a sideline position. Vaginal birth is preferred. Episiotomy with vacuum or forceps-assisted birth may be done to decrease the time of the second stage of labor. Routine intrapartum antibiotics are given for prophylaxis. Oxytocin is given immediately after birth to prevent hemorrhage and changes in hemodynamic stability. In the postpartum period, monitoring is essential. The first 24 to 48 hours are critical as the maternal circulatory system returns to pre-pregnancy state. The woman may need as much assistance at this time to decrease stress on her system. Other medical disorders in pregnancy include anemia, pulmonary disorders, integumentary disorders, neurologic disorders, and immune disorders. You can learn more about these disorders in your textbook. The effects of alcohol and drugs on pregnancy are well known and include the continued use of substances despite related problems in physical, social, or other interpersonal areas. Substance abuse usually goes hand in hand with another psychiatric disorder. This is a dual diagnosis situation. As previously stated, the damaging effects of drugs and alcohol on the fetus are well known. Both can pass from the mother to the fetus. Smoking is considered a drug and can have serious effects such as bleeding complications, miscarriage, stillbirth, prematurity, low birth weight, and sudden unexplained infant death. Less than 10% of pregnant women who abuse substances receive treatment. Social stigma, labeling, and guilt have been shown to be barriers by Brady and Ashley. Losing custody of the baby is a big fear and a primary reason that many mothers might not report using. It is very important that a substance abuse screen be completed as a part of the initial assessment on the first prenatal visit. The 4Ps screening tool can be used to identify pregnant women who might need a more in-depth assessment. The 4Ps include parents, partner, past, and this pregnancy. Urine toxicology testing is often performed. Drugs can be found in maternal urine days to weeks depending on the drug. Meconium and hair can also be analyzed to give an indicator of drug use for a longer period of time. Care management. Intervention begins with education and possible admission to treatment centers. If detoxification is required, it must be done in an inpatient area with medical management of the withdrawal process. Methadone maintenance is a standard of care for women who are dependent on heroin or other narcotics. Pregnant women who use cocaine or methamphetamine should stop immediately. Both are stimulants with vasoconstrictive effects. A woman can possibly take 1 dose of cocaine that can lead to an increase in blood pressure and placental abruption. Breastfeeding is definitely contraindicated in women who continue to use amphetamines, alcohol, cocaine, heroin, or marijuana. Substance abusers are difficult to care for, particularly during the intrapartum and postpartum periods. Substance abuse is an illness. Women deserve to be treated with patience, kindness, consistency, and firmness. Before discharge, the home situation must be assessed to ensure that it will be safe for the infant. Support systems should also be assessed to ensure that there is someone available to meet the infant's needs if the mother is unable to do so. The nurse should have involved family members early to have them become actively involved before discharge. If at any time the infant's well-being is questioned, the family should be referred to Child Protective Services. The nurse needs to be aware of the hospital policy regarding referral to Child Protective Services. If the mother is not in treatment, there may be a hospital policy in place that states that a positive drug test is an automatic referral to Child Protective Services. Next, this is a question. During a prenatal visit, the nurse is explaining dietary management to a woman with pregestational diabetes. The nurse evaluates that teaching was effective when the woman states, "I will need to eat 600 more calories per day since I am pregnant. I can continue with the same diet as before pregnancy as long as it is well balanced," or "diet and insulin needs change during pregnancy," or "I will plan my diet based on the results of urine glucose testing." The answer is diet and insulin needs change during pregnancy. This concludes this lesson for this unit.